BC Pediatric Society Conference. Thank you. We would like to get going on the rest of the day. Our first presenter is Dr. Barbara Fitzgerald. Barb is a developmental pediatrician who has spent her career working with a wide range of children with developmental challenges. She has run an outreach program to Vancouver schools for 17 years, specializing in school-aged children with learning and behavioral challenges. Barb is a medical director and consultant developmental pediatrician at Alderwood Family Development Centre, where she treats children with complex behavioral and mental health concerns. In her private practice, she sees children for concerns regarding possible autism spectrum disorder and other challenges. She was the Assistant Dean of Student Affairs at UBC, where she started an award-winning medical student wellness initiative. Ties in with today's theme. She teaches child development in UBC Medical School and founded a charity, which I expect most of you have heard about, called Mum to Mum, that pairs mentors with socially disadvantaged mothers. Barb is also the mother of 4 wonderful young adults and has been married to a very patient psychiatrist for 30 years. Barb is going to talk to us today about an approach to office-based assessment of autism in higher functioning children.
Thank you.
Thank you.
Hi, everybody. This is always my favorite group to talk to because I feel like you guys are really out there in the trenches and you really want to know how to make your practices go better. So this is going to be a really practical talk, I hope. I've posted a couple of things on the website. One is just so the talk will be posted on the website, but I also put together an autism screening questionnaire for you. So download it, use it. It's 23 questions. I know you guys would have rather 5, but it is 23. You can pick and choose a bit, but it'll be a bit of a guide for you to help you in your screening. What I mostly want to focus on today. Well, I also, on the website, I posted something else. I put just the DSM-5 criteria for autism. Because what I'll often do at the end of an appointment, I have that on my report template, and I'll just go through and look at them and bold them and go, oh, yeah, this child has the criteria. I'm sending them for formal assessment or going to do it myself. So those resources are there for you. And I want to talk first about why bother, because some people are like, why do you need to put a label on these kids? These kids didn't used to get diagnosed with autism. Why do we need to bother? And it's because these kids are suffering. I often say to parents, if the choice was that we were going to all the teachers were going to call your child normal, or they were going to call them autistic, yeah, I'd rather normal. That's not the choice. The choice is bad, or having needs that need to be supported. Bad child, bad parents, etc. So that's the choice, and obviously much better to be able to see the child through the lens of autism and help them. One of you guys referred a child in to me yesterday she's 12 and a half, and she definitely had been labeled bad and rude. And she does sound rude because, like many people with autism, she doesn't know how her voice and facial expressions are coming across. She's not rude at all. She's so sweet, so wants friends, and has no clue how to be successful in that. So these kids don't meet their potential if they're not diagnosed. Over 6 kids are eligible for $6,000 of government funding and $18,000 for the school. So supports are available. The under 6 kids, $22,000. So don't wait, because if we can diagnose them early and they get 3 or 4 years of intensive funding, it's amazing. And I actually diagnosed a kid at the age of 14 months last week. Absolutely clear-cut, not low functioning, developmentally typical child with autism. I had some help because the mom's a pediatric nurse, and her older child had already been diagnosed with autism. This is not an attempt to make every kid be normal. I have a sign in my office that says normal is a setting on the dryer. This isn't about trying to make every kid fit into a box. Just get him into hockey, he'll be normal. It's not that. It's about really having a deep respect for children and the way that they present and what their needs are. Most of the time they don't get diagnosed till age 8 or 9. And by that time, they already have often had a pretty poor self-concept for them. If you live rurally, you're less likely to be diagnosed. If you're poor, if you're First Nations, if you're Black, and if you don't have a consistent doctor. The kids that have the obvious signs, they get referred in right away. But the high-functioning kids don't present with hand flapping and toe walking and those really obvious stims. They're stimming inside their head. Like the kid I had a couple of weeks ago who wanted to recite the names of every single American president and their major achievements since Abraham Lincoln. He's stimming, but it's not apparent on the outside. So what I realized so for some of you who don't know, I left Sunny Hill in February and I'm in private practice now. And I realized how hard your job is. So, at Sunny Hill, it was so nice because I'd get the forms, everything was completed, and it would say, do an autism assessment. And that's all I had to do. That was pretty easy. But now that I'm in private practice and I see that the presenting complaint is behavior, one word from the GP. And it's kind of like, oh gosh, okay, what is this? And so I put together this list, which are the things that commonly kind of stump me and make me think. The ones with asterisks, I think, are the trickier ones. I think the other ones are more self-evident, so I won't focus on those. The kids who present with an intellectual disability or giftedness or learning disabilities can be tricky. But you know what? Just get down and play with them. A child with an intellectual disability, just always think what their developmental age is. So I always just do some rough math in my head. So for example, if that child's IQ has already been found to be 70, so they're developing at around 2/3 of normal, and they are 8 years old, so then what are they? Oh, okay, so I'm expecting a 5-year-old. So I get down and play cars. And when you play at that child's intellectual level, that's when you start to see lovely social skills, and it becomes easier to figure out whether or not they're atypical or not. Gifted kids can be kind of tricky on the surface because maybe they don't have lots of friends, because there's not a lot of kids maybe that they feel comfortable associating with when they're gifted. But when you talk to them, you have a lovely reciprocal conversation. They use nice gestures. And when you get the history from the parents, they had beautiful imaginative play, and there's no real atypicalities. So those kids, you can figure out. Nonverbal learning disabilities is something that never made it into the DSM, any of the DSMs. So when the profile shows that there are nonverbal reasoning difficulties, some people refer to that as a nonverbal learning disability syndrome. And it was said to be associated with people who had mental health issues, children who had difficulties reading social cues, interpreting facial expressions. It's been shown now that probably most of those kids that we diagnosed with nonverbal learning disability syndrome probably had autism. So it's not that much of a difficulty to figure out. Kids with language delay and disorder actually are some of the really more interesting ones. I really rely on the speech pathologists for this because this is all they do. So if it's a young kid who's still getting speech in the community, speech therapists only see kids with speech and language delay. They only really have two differentials. Do they have speech and language delay alone, or do they have autism associated with it? And so they can be really, really helpful. But the kids with speech and language delay, they still point, they still use gestures. And again, when you get down and play with a 5-year-old who doesn't really have very much expressive language, and you play goofy games, and they start giggling when you crash the tower down, and you realize there's so much shared enjoyment and so much social interaction. If you can remove the language component, it really helps you figure out whether or not it might be autism. The other thing is that when you see these kids over time, the kids with speech and language difficulties, they get better. So as they learn more language, they look less autistic. The kids with autism get worse because the social demands are increasing. So that's one of the key clinical findings in them. They don't have the repetitive mannerisms or intense interests as well. Kids with anxiety are also tricky, but I think this is where we shine as pediatricians. We're so used to making people feel comfortable. Kids, as they warm up with us, you start to see less of the shyness and more typical social skills. So I actually don't find this to be too much of a problem. Now, kids with autism often also have anxiety, and they kind of get into this vicious circle where they know that they're unsuccessful socially, so they get anxious before they go into a social situation, and then they are unsuccessful, and it increases the anxiety. So they are frequently comorbid, but it's not that difficult to distinguish between a pure anxiety disorder and anxiety plus autism. Kids with anxiety still have friends, they still have imaginative play, and they rarely have repetitive mannerisms. The other thing I notice when I'm talking with an anxious kid, even an anxious teen, you're talking to them and the whole time they're looking at their mom for confirmation or to get her to answer. Kids with autism don't do that. FASD is another one that could be a whole lecture in itself, so I'm going to keep it really brief because a lot of you know that FASD has been an interest of mine for years. What I learned when I branched out more into the autism world is that kids with FAS don't get diagnosed with autism. I know I have had blinkers on for 25 years. FAS, you can't have anything else. You can't get chickenpox, you can't get asthma, you've got FAS. And because FAS is a bit of a vague diagnosis, so many different things can present in a child with FAS, that we are very good at just ignoring some of the quirkiness in them. One of the new psychologists at Sunnyhill came to me this year and she said, I've been here for 3 years and I've seen 3 patients who are First Nations come into the autism clinic. Do First Nations kids not get autism? And I said, I don't think there's any genetic thing that means that First Nations kids don't get autism. We're sending them to the FAS clinic, and I think that we're missing a lot of cases of autism. This is just for your interest. Steve Wellington always puts this up, and I find it helpful, just as 16 gestures by 16 months. So babies gesture. So by 1, kids are already pointing, usually with like an open hand, but they're pointing. So think about gestures is one of the more objective signs you can use when you're thinking about autism, because parent report can be difficult, but they either use gestures or they don't, and you will see them, and you can ask some questions that make them more likely to use a gesture. I'll ask a child, how big is your dog? Pretty big. How do you describe how big your dog is without, doing a gesture? So they should be all kinds of gestures, blowing kisses, shh, no, those kinds of things. So how do they present to us? Wow, anything, right? They come in with behavior challenges, academic challenges, and often by the time they get to see you, they're not presenting with query autism usually, but they do have previous diagnoses of ADHD, oppositional defiant disorder, developmental coordination disorder, sensory integration disorder, learning disabilities. And like when you get to 3 or 4 diagnoses, you got to stop to think, is there maybe one unifying one? I often say to parents, it's like you've come in and I've said, oh, you've got lymphadenopathy, you have pus on your tonsils, you have a fever. Maybe this is one thing. Maybe this is strep throat. So what are the clues for you guys that generic kid that comes in with behavior learning problems could have autism? Socially, they don't have friends. It's such a big one. Like, what other condition causes you to have no friends? And you have to ask about it. Like the child I saw yesterday, the mom said, oh, she's very socially outgoing, and all the preschool reports, because they always want to be able to put in something positive. Even from preschool, this 12-and-a-half-year-old's reports were very social, very outgoing. But at her birthday party, she invited 8 girls and 1 came. She has no friends. Nobody calls her for play dates. What else causes that? So you have to ask yourself that. The child may want friends. So that's an old autism diagnosis, that kids with autism aren't social, don't want social connection. They may want friends, but they're really unsuccessful at it. Behaviorally, they're rigid. Other kids don't like them because they're bossy and inflexible. and they often have severe behavior challenges. Kids with autism don't recognize social hierarchy. So a little boy I saw yesterday, he was upset because the library teacher was reading a book and she didn't pronounce a word the way that his mother pronounces it. So he got up and pinched her. And, pinching is not such a terrible thing on the playground, but you really don't do that to your library teacher. And he doesn't recognize that. So these kids get in huge problems. And the teachers are writing you saying they need support. And you're like, does their ADHD or oppositional defiant disorder really explain that? And then another really big one is their adaptive skills. So, when a psychologist does an assessment, an intellectual assessment, they look at IQ scores. So child has average IQ. And then as a check and a balance, they do a long questionnaire with the parents saying, how does your child behave in everyday life? Can your 5-year-old cross the street safely? Can he answer a telephone? Can he choose appropriate clothes for the weather? Does he have a best friend? So in all the different domains. How is he? And I just ask parents, okay, leaving aside how intelligent he is, what age child are you looking after? So like this 12-and-a-half-year-old yesterday, the mom had to every step of the way, don't forget your jacket, don't forget your water bottle. Do you want to sit here, dear? And she wasn't an overbearing parent. That child needed that. And it went way beyond ADHD because this 12-and-a-half-year-old asked for a Fisher-Price kitchen for her 12th birthday. And she has average intellectual abilities. So her overall maturity is so much lower. I said, so she's 12-and-a-half. Would you leave her to babysit a 2-year-old and a 4-year-old? And her mother said, are you kidding? I'm hesitant to leave her by herself. So her adaptive skills are really low. And there's only 2 conditions that cause that discrepancy between intellectual abilities and really low adaptive skills: fetal alcohol syndrome and autism. ADHD a little bit, but it's only in specific domains. Kids with ADHD don't play with My Little Pony at age 18. So it's in different domains. Yes, they're scattered and they need more support for daily life stuff, but not in all the domains. So start with an open mind because they're not going to present classically. If they presented classically, someone would have diagnosed them at age 3. So these are not the kids that come in flapping their hands, rubbing their hand in front of their face and staring off into space in the corner. They come in and they may have very good superficial skills. People have worked with them. So they'll say hello, they'll look at you, they'll say, how are you? When we do a formal autism assessment, we are required to spend 40 to 60 minutes directly playing and talking with a child because kids can hold it together for a certain amount of time, but they can't hold it together for longer. And later I'll try to give you some shortcuts for that. They may have had an assessment. They may have had 2 assessments that were negative. Don't let that cloud your judgment. Assessments are done by a variety of different people, often not by pediatricians. I think that we are in a really good position because we're trained differently from psychologists. When you see a child who the tests are coming up negative, but you have a really strong suspicion, your clinical acumen says this child is sick, you admit the child to hospital. You don't say, oh, tests are negative, off you go, and then later find out the child died. That's not how we practice. We don't practice based on scores on a test. Psychologists are trained more by that. And so I think that use your clinical acumen and push for another assessment if your impression is that the child may have autism. The other thing is that the assessment for autism may have been done when the child was younger, when we have, there's a lot more leeway for different kinds of social skills. So if a 2-year-old goes up to someone at the supermarket and says, why are you so fat? We're embarrassed, but it's not atypical for a 2-year-old to do that. But when a 10-year-old does that, that's really atypical. So they may have kind of passed that part of the test when they were young, but they won't pass it when they're 10 because we're expecting so much more of them. So probably the most important thing I want you to take away is that if you see a child with a bunch of diagnoses or no diagnoses and they are really not managing, They're not managing at school. They're not managing behaviorally. They're not managing in their family, and they don't have friends. Really, really think about it and do some proper screening. I won't go, this is way too busy a slide, but this is what I posted online for you to just use. What I want to this is a DSM-5 criteria, and I just want to highlight a couple of things, because things changed a bit in the DSM-5. So there's two categories, social communication and social interaction, so social skills, and the second one is behavior. You need something from all three categories in the social interaction piece. So in the first one, social emotional reciprocity. So they don't approach other kids, don't make friends, don't share interests, and don't have a back and forth conversation. Talk about that in a minute. Number two, they don't have good nonverbal communication. So gestures, pointing, reading facial expressions. And then difficulties in understanding and maintaining relationships. And so also part of this one is whether they share imaginative play with peers. So friendships. So you need something out of each one of those categories. And then you only need 2 out of 4 of the behavior domains. So you don't have to flap to get a diagnosis of autism. You don't have to have any repetitive motor mannerisms to get a diagnosis of autism, or to have autism and be really suffering from it. So the first one is repetitive motor movements. This could just be something as simple as lining up toys and being rigid about when they've lined up their toys and they don't want someone to disturb their order. Insistence on sameness. So these are the kids that the mothers have learned that they have to front load them like crazy. Since their first days in daycare, the reports have said difficulty with transitions. This 12-and-a-half-year-old I saw yesterday, the school bus driver had reported that if he ever has to go a different route because of construction, she completely freaks out. So insistence on sameness. And then the other two categories are fixated interests or atypical interests. So ask, every 5-year-old goes through a dinosaur phase. That's completely normal. But if they go through a dinosaur phase that lasts until age 8, so beyond the other kids, and they watch dinosaur videos and wear dinosaur clothes and study dinosaurs on the internet and decide to become a paleontologist and only talk about dinosaurs, that starts to become a little bit more intense. When the parents say, like I had one set of parents that had a vacation home somewhere in California, and they actually couldn't drive there anymore because it passed by some paleontology museum, and they would have to spend 2 full days in the paleontology museum if they went by it. So now they fly, because that kid was so rigid about having anything to do with dinosaurs. So, or atypical interests. So, the child yesterday is just really, really interested in volcanoes and hurricanes. And so she follows blogs, she talks nonstop about volcanoes and hurricanes, wants to be a meteorologist, but interestingly won't go outside when it's raining because she's terrified of weather. So interesting. But an atypical interest. I have another kid who every Saturday has to go to the mall and has to flush every toilet in men's washrooms around the entire mall. So, and he won't be satisfied until he's done that. He has to lift the seat up, flush the toilet, put the seat back down, move on to the next stall. So atypical interests. And parents sometimes don't volunteer these. So things that were in the new DSM, things that were previously diagnosed as Asperger's, pervasive developmental disorder not otherwise specified, now come under the autism spectrum. So this means that the incidence has gone up. It's now like 1 in 66, 1 in 68. Some of that's because we've broadened the criteria, and some of it seems to be a true increase. I'm seeing a lot of kids with older parents, particularly older dads, and increased paternal age seems to be a big factor. The etiology is mainly genetic. I used to only do microarrays on the kids who had an intellectual disability, but I've started doing it on all the kids because I'm getting all kinds of interesting results. So how a formal assessment works, I'll just briefly tell you. When you send them to BCAN, they will have an assessment with a psychologist or a developmental pediatrician that consists of 2 parts, a standardized interview and a standardized play-based tool. I'm going to go over some of the parts of those tools because the good thing about these tools, unlike an IQ test, where we're not allowed to pull elements of an IQ test out and use them with a child because there's a practice effect, and if they ever go to have an IQ test, you'll have messed up the results. If a child can learn how to be not autistic from you doing the autism assessment with them, they don't have autism, or you're magical. Most of the questions on the history relate to when the child was 4 to 5 years old. So that's how they've standardized it. So in your office, it actually can be really helpful to ask, think back to when the child was 4 to 5, the year before they started kindergarten, and think about how they were in daycare and the kinds of things that teachers said. Okay, so when you're taking your history, these are some of the things that you're going to take, and this is what's on the list that I gave you. So does the child make consistent eye contact? Is it flexible? I just say to the mom, is this a kid who you always had to say, look at grandma, she's talking to you? Does he smile back at people who smile at him? Did she play imaginatively with peers? You've got to delve into this one because everybody says yes. And then you find out what they were calling imaginative play was either completely lifted off of YouTube or a video that they've watched, and it's just a recreation from their memory of what they saw on TV. That's not imaginative play. Or it's very repetitive, or it's actually just creative play. So making a really, really amazing city out of Lego is not imaginary play. But if you take the Lego people and say, I'm going to the hospital now, that's imaginary play. So really find out, you guys know what imaginary play is. You've got to ask them because parents don't know. And it also, if the parents are completely scaffolding it, that's not imaginary play. And if it's just that they have an older sibling, an older sister who's really good at imaginary play, and it's like, and you can be the dog, that's not imaginary play for the kid who's the dog. So peer relationships. Did the child approach other kids? When the mom drops off at daycare, does the child run in to join the other children? And does she do it successfully? So when you go to the park, does she try to join in with other kids? Or does she just barge in not realizing, I'm 6 and they're 12. They probably don't want me playing in their soccer game. But not recognizing that. So just the not approaching isn't the thing. And then how do they respond when someone approaches them? So I usually give the example like, Johnny's playing in the sandbox. He's got his new pail and shovel. He's making tunnels. Sam comes up and says, can I play with you? Johnny says, sure. So he allows Sam to join in. And then Sam says, hey, how about if we take the pails and get water from the drinking fountain and turn it into moats? No. We are making tunnels. If you want to make moats, leave. So he would rather play by himself than be flexible in any way. They often do, when we ask, do they join in with other kids in play? They'll join in the game of tag, but they have to make the rules. So I'm never it. If you touch me, it doesn't count. You have to touch me with your left foot off the ground, so that didn't count. I'm not it. They make all the rules and are extremely rigid, which is why other kids don't want to play with them. Did they have friends? And not friends that their parents orchestrated. Not friends that, yeah, they have friends when they go to Girl Guides. No, do they have actual friends who call them and ask for play dates? Do they know the right kids to call for play dates? Or do they just get their class list and pick somebody who has never shown any indication of interest in them, that they'll go down the list and ask them to play with them? So do they actually get play date invitations and have real friends? And what do they do when their friends came over? I had one person recently say, yeah, he has lots of play dates. What does he do? Well, he likes to take old cell phones and scratch them on the sidewalk and then hold them up to the sun and observe the patterns that the scratches make. Oh, what does his friend do while he's doing that? Well, they watch. That's not a play date. And those kids don't come back for a second play date. Did they show things to the parent? And did they take delight in showing things? So think of yourself. If you like, let's say I really love East Indian food and I find an amazing East Indian food blog that I want to share with Jane because she also loves cooking. It's going to make it more fun to me that I found that blog to be able to share it with someone else. When the child's enjoying something, and you can even see this in your office, do you feel like you could walk out and they'd be having just as much fun? Or when you read a funny book together, do they look up at you and smile like, isn't this hilarious? Aren't we having a good time together? Not just him having a good time. None of the high-functioning kids do this. If they do, it's almost diagnostic of autism. Kids with autism, nonverbal kids, pick up their parent's hand, use it as a tool, put it on the toy, and it's like you are the mechanical arm that makes the toy operate. The high-functioning kids almost never do that. Darn. Did they offer comfort? And get examples. So offering comfort is not like, Mom, why are you crying? Like, that's an unusual thing that Mom is crying. I'm curious. No, Mom, what's up? Arm on the shoulder. What can I do? Do they actually offer comfort? Offering comfort is also not just something rigid, like 2-year-old scrapes her knee on the sidewalk, and despite the fact that that 2-year-old is terrified of Band-Aids, this 8-year-old is going to put a Band-Aid on the 2-year-old because that's what you do when people have a scrape. So completely inflexible. Did they respond appropriately to people? So when the checkout clerk says, "What's your name, little boy? You're so cute," and they don't respond, or they respond in an odd way. Do they respond to greetings? This 12-and-a-half-year-old, the mom said that still when she leaves daycare, the daycare staff all say goodbye to her. Mom has to remind her you need to say goodbye to people. You don't just get up and walk out. And you'll see these kids in your office. You say, "Thanks for coming in today. It was really nice to see you." And they just get up and walk out. And you're like, whoa, what happened there? Use of gestures. Do they point at things to get you to look? Did they use gestures like, as I mentioned before, waving, blowing kisses, etc.? Did they play imaginatively? And really, I like to hear they played house or they played restaurant, they played shop, something that's really imaginative. Did they copy you in household tasks? Most little kids, when their parent picks up a cloth to clean, they'll pick up a cloth. When the parent is mowing the lawn, the kid will pretend to mow the lawn. Do they do that? And then later on, do you see them pretending to be you? So those of you with kids will have had the experience of you're cooking in the kitchen and you hear your kid going to their dolls. "You are bad. You're going to your room. You need a timeout." And you're like, oh my gosh, do I sound like that? Please don't tell your teacher that I talk like that. But they're being you. They actually are imitating you. Do they make small talk? These kids never make small talk. They walk into the kitchen and instead of saying, "Oh, it's raining again, my soccer might be canceled," they walk into the kitchen and say, "So on the vlog on tornadoes today, it turns out that there was a tornado in blah, blah, blah." And you're like, whoa, I just got up. No good morning, just like no small talk. They don't have reciprocal conversation. And this is one where it's really hard for pediatricians. We are so good. We spend our whole lives trying to make kids feel comfortable. And this is a tricky one. You actually have to feel uncomfortable and let the situation be more natural. So you have to actually say something like, "Oh, it's such an interesting thing happened on the way to work today. I had such an interesting thing happen." And they say nothing. And you sort of up the ante. "Oh my gosh, I had the most amazing thing happen to me on the weekend." Anyways, about tornadoes. And you're just left feeling like a complete idiot. And when you have that feeling, that's autism. They don't follow your leads. These are in the dramatic example. It's like, "Oh, I had such a great weekend. I want to tell you about my weekend." And your conversation partner says, "I had a horrible weekend. My sister got sick. I had to take her to the hospital." You don't then say, "Oh, well, we went to Whistler and stayed at this amazing hotel." No, you don't do that, but these kids do that. Did they ever make inappropriate comments? So this was the, why is that lady fat? Use odd language. Jane Finley sent me this fantastic patient who was like born and bred in Vancouver, but he only speaks in an upper class British accent. His first comment was to me, he said, I would like to know if you've got the skills and abilities to appropriately assess a person such as myself. I said, Dr. Finley wouldn't have sent you if I didn't. So odd language, bits taken off of videos, or just pedantic language that isn't explained because they're gifted. So you know when you're talking to a kid and they come back with, well, I would rather do blah, 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 and you're like, okay, most 4-year-olds do not talk like that. And you're sort of like, that was an odd, formal way of answering my question. And then the restricted repetitive behaviors. So we've talked about this, the preoccupations, intense interests, repetitive behaviors. Unusual mannerisms can be subtle. So it can be like the kid I had yesterday just does this. And I think what he's doing is he likes to sniff his fingers. And so he's always like that. It can be something as simple as turning hands like that, or this. And it sometimes is flapping, but not always. Unusual sensory interests. So did they love to stroke their mother's hair? This 12-and-a-half-year-old still at 12-and-a-half strips naked every night and rolls around in one of those super furry blankets from Indigo because she loves the feel of it. I had a boy last week who's 10. His mom takes him to the river in Maple Ridge every single day. He strips naked and rolls around in the mud. But that's not something you kind of come in and report. Like, she just does that. She thinks it's her experience of her child. So sniffing toys, licking toys, and significant sensory aversions. Most of these kids won't wear jeans. They say they're too crunchy and they don't like the feel of the waistband. So unusual sensory things. And then transitions, were they difficult? In terms of your observations in the office, I've just divided them into language and communication, reciprocal social interaction, imagination, and then the behaviors. And we've already talked about some of these things. So again, like, just these targeted observations are different from our normal pediatric observations. We're not trying to make the kid feel at their most comfortable necessarily. We want to see how they naturally play. And it's really hard. This took me a long time to be able to put out a variety of play materials, see that the child can't really play imaginatively, and not immediately jump in to help them. Sit back and see what they do. Watch them as they get more and more repetitive with their play. Maybe they just consistently interact something violent that they see on their video games, crashing things, and then step in and try to say, let's have a soccer game together. And the kid completely ignores you and just keeps doing his own thing. Or do they let you in and allow you to have a nice sequence together that's interactive? So I just put out playthings, so depending on the age of the child. For older kids, what we do on the ADOS that is simple to do is we just take a little bag of 10 random objects, popsicle stick, a cocktail umbrella, a tiny ball, a block, a hair elastic, a shoelace, like really random stuff. And then I say, I'm going to pick 5, and I'm going to make up a story or a commercial or a video game. And then I do it, and I make it really simple. I set the bar really low, and the idea is to show them that I'm pretending that a popsicle stick can be a person. And then you say, now you do it. And this even works with 16-year-olds because they'll make up a video game or a commercial. See if they can actually make something be something else, and you'll see for yourself whether they actually play imaginatively. You will be shocked at some of the kids that just take them, and they love to make a tableau with it. But there's nothing, there's no story. It's just they've figured out a really, really cool way to pile everything on top of each other because they're all budding little engineers. And then have conversations with them. So we've talked about this. And you want to start by just really subtle things like, oh, my dog was so silly yesterday. And wait for them to say. So I did that 4 times in a row with this 12-and-a-half-year-old yesterday, and every single time her response was, didn't ask me a question, didn't express interest. So that's atypical. And that doesn't really occur in other things. Am I nearly done? Okay, 2 minutes. I started 2 minutes late. So we've talked about the language, so I won't talk about that. We've talked about gestures. One thing that you can do that we do on the ADOS is we have a very simple puzzle, and you purposely withhold a couple pieces and say, here, do this puzzle. I've got a couple extras if you need them, and see if they actually ask you. So right now, look down at your laps and ask me for more puzzle pieces. You cannot do it without looking at me. You absolutely can't. They can. Okay, so play we've talked about. The last thing I want to mention is that I asked them about emotions. So what does it feel like to feel sad? What does it feel like inside to feel angry? The high-functioning kids cannot tell you. They don't know the difference between sad, angry, and sometimes afraid. They cannot describe it to you. And that's a really big clue. They really are struggling with emotions. And then finally, I ask about human relationships. Tell me what a friend is. I'm from Mars. We don't have friends on Mars. What is a friend? Oh, a friend is something you play with. Oh, like my cell phone. I play with my cell phone. Yeah, like that. Whoa, okay, that's a big clue. So do they have an understanding of what friendship really means? What do you do with friends? I always ask them, what's different about the way your mom feels about you compared to the way your mom feels about your friend? And yesterday's kid said, my mom protects my friend more because he's younger. Whoa, anything else about the difference in the way your mom feels about you? Nope. What about marriage? Are you going to get married when you get older? Yeah. Why do you think people get married? So at age 5, to have babies is a reasonable answer. But at age 12, best one I had last week was to ensure that the woman changes her name. I said, any other reasons why people would get married and stay together for their lifetime? Nope, really, it's just that. Whoa, and that, it can be that subtle. I will flip to the end now. This is the last one. I like to use this. You can get this off the internet. There's many versions of this. Kids with autism don't have what we call theory of mind, or the ability to put themselves in someone else's shoes. So this is Sally. Sally has a basket. This is Anne. Anne has a box. Sally puts her marble in the basket. Sally goes for a walk and takes the marble out of the basket and puts it in the box. Now Sally comes back. Where is Sally going to look for her marble? The kids with autism say the box. They can't get that Sally walked away and doesn't know the marble's in the box. So that takes like 2 seconds to do, but it's a fun one. So think about, they present with functional difficulties. This is like when you're in the emergency room, the chest x-ray is negative, but you know that child has something respiratory going on and you're not going to let them go home, even though the test seems to be negative. These kids have functional difficulties. Take a history focusing on 4 to 5 years, and remember that the presentation in high-functioning kids is going to be subtle. That's why they've been missed. Getting a diagnosis can be a huge relief. When I told this single mom yesterday that her daughter had autism, she sobbed. She had been blamed for being the single mom of a single child, and it's parenting, and you're bad, and your child's bad, and you made bad choices with her father. And no, your child has autism. You are an awesome mother. So it makes a big difference to people and to the kids. Thank you.
That was great, Barb, as always. I have about 40 questions, so I'll refrain. And we've got time for one question. Any questions?
Yes.
We see these kids in the office say they have one of the parents were sent in with speech delay after they called and said it was a child with autism, but the parent's not ready for that. So the diagnosis for the referral, et cetera.
Yeah. You know what?
I had parents that I know, if I say, okay, I'm referring and sure your child has autism,
Yeah, so a couple ways that I approach that. I mean, sometimes it just takes more visits for them to trust you.
But it's hard because you want to get the process.
Exactly. One thing that I do, and I do this with ADHD as well, and it's really worked. I'll never forget, and I've told you guys this story before, but it really resonated with me. It's an ADHD story, not an autism. But the parent had actually seen 2 other pediatricians and been diagnosed with the kid had been diagnosed with ADHD. But the last pediatrician spent under 15 minutes with the child and was already pulling out her prescription pad to write the bifenton prescription before the end of the quarter hour. And the parent left and said, I will never go back to see that pediatrician again. I spent an hour with the child and did some neurodevelopmental assessment and showed the parent how the child had made lots of mistakes because of their inattentiveness and their impulsivity. Similarly with ASD, I'll show them the picture book that I used and how the child didn't recognize any facial expressions. So I'll show them these things so that they see that I got their child. And I'll never forget that parent at the end of the ADHD assessment, I got out my prescription pad and wrote a prescription for bifenton. And she asked me for it. And I said, why? I'm really confused here because you came in here with guns blazing saying that you hated this other pediatrician for doing it. And she said, because you are prescribing something for my child. She was prescribing for a condition. And I think parents just want us to have seen their child. The other way that I approach it in high-functioning kids is I say, this is really hard news for you to hear, but autism is a spectrum, and I think of this kind of autism as like a learning disability. So if your child had a learning disability in math, he just isn't picking up on math when the teacher teaches it the way that other kids are, and we need to get him a math tutor. When your child has a learning disability of social communication, same thing. He's not picking up on all the things that other kids just somehow learned by osmosis. And we need to get special tutors to help him develop his social communication skills. This isn't the kind of autism where the child's mentally handicapped flapping in a corner. He can do great things, but he's not going to do great things until we get him over this hurdle. He needs to learn this. Same as if he had dyslexia, he may turn out to be an amazing contributor to our planet. But if he can't read, he's never going to get there. So we've got to get him from here over this hump to here. So I don't know if that helps, but it's... Thank you guys very much.
Thank you very much, Bert.
Oh, thank you.